Oh, that's cute. I like that. Sorry,
No,
but like,
but
using it to like blowing them up and stuff is really
Oh, yeah, we
and sometimes
can.
it's too. I've gotten a lot of tactics.
Dr. Duke, if you're talking, we can't hear you now.
There we go.
Okay. We can never hear. Where are we?
We can never
hear
hear
you
you.
either. You're always
This is a problem with our group. If you hear
where
it.
we are.
About restaurants in Savannah and the Cuban place, so that's why y'all couldn't hear me talk. But I appreciate your interest, and we definitely want to get you connected. Okay, I believe this is where we left off. But my computer.
I think we were around slide 65.
I would not. Good for her. That was Phoebe paying attention.
We'll talk about that. Yeah, I think we got that far. Okay, let me find out where we were.
Can you just finish it today?
Because we got to get through all of this today.
He just said we gotta get through all of this today. If he whips out a third
Oh,
slide set or another slide.
oh, these are cool. Oh, fun straws. Funny, silly straws. Yeah.
Yeah, I know we talked about what makes be a GME agent, miscellaneous rules. I'm looking at folks here in Savannah. You got Okay, 55. I can go with 55. Okay. And your 55 might be a little different. Okay, yeah, we had talked about substations and how currently central fill is very restricted and not allowed, but they are actually going to consider that, talk about that at the April Board of Pharmacy. They have some proposed rules. If somebody, don't confuse yourself before our exam, but if you go on the website, you can actually see their proposed rules for central fill. Realize this may be something you get involved in your practice down the road, working in a central fill pharmacy. You may be filling for patients at that pharmacy, you may be filling some prescriptions for other pharmacies in your area. Probably going to be in the larger metropolitan areas only. And I will update you after the April meeting to let you know what happened in there. Something that's similar to that, when we talk about substations and how they're prohibited, if you have a place to drop off and pick up prescriptions, it's not a pharmacy. There is a special provision to allow for your prescriber to request that your prescription be filled and delivered to them to be given to them, a patient, in their practitioner's office. A lot of times this is done when they need to do some training on how to administer the drug, injection or something like that. But do realize that that might sound kind of like a substation, but it's not. It's a practitioner's office, and they specifically request it so that they can provide it to the patient. That is okay with written authority. Must be followed by written authority. Okay. This is something we've talked about a few times. This is where it's actually written in the rules and regs of the Board of Pharmacy. People all the time asking about patients bringing prescriptions back and demanding that you give them their money back. They don't like this drug, they don't want to take this drug, this, that, or the other. This is where it is written in the rules that it is, not only do you not have to take that back, it's actually unlawful to accept a refund or otherwise, as far as the way it's termed in the rules. Previously dispensed medications that have been delivered to the patient or the caregiver. Once it leaves that weight bin out front, you give it to them, they've had possession of it, they can't bring it back. The idea here is that you don't want anything that could be tampered with, adulterated, otherwise, and then put it back into stock. You can't put it back into stock and dispense it again. So you do not have to take that back or give the patient a refund. Now, where that conflicts with what happens in the real world is that all of us work for employers now, and they want to make sure every patient, every customer is always happy. By golly, we will give them their money back. They can give them their money back, but you cannot take the drug back. You cannot put it back in stock by any means. Okay? So as far as, they can give their money away all day long, but this backs you up saying that you don't have to. It's actually considered unlawful to accept a refund or otherwise previously dispensed drugs. Okay. Drug disposal, again, we've talked about this a few times. This is, as often is the case, the Board of Pharmacy regulations were written to match the federal regulations. The DEA has something that's called the Secure and Responsible Drug Disposal Act of 2010. So it's been around a while. It was new in Georgia in January of 2016, which hasn't been that long. And basically it, again, codified or put into the regulations these drug disposal bins that can be actually mounted in your pharmacies. They have to be physically attached to the floor. They have to be locked, obviously, so people can't get in there and go through the drugs that have been returned. Things to know about this for exams and practice. Realize this is a DEA registered site. Okay, you have no idea what drugs are going in there. You know, so they can put in their blood pressure medicine, they can put in their fentanyl patches, they can put in a bag of Skittles, you know. But because it can have these controlled substances, and the idea is it's trying to help with the opioid crisis, getting these unused medications off the shelves and out of people's homes. There are different studies that say well over 50% of the people that ever get addicted to opioids for illegitimate purposes got them from someone who had these just stored in their house or in their drug cabinet or something like that. So it is a good idea to get those out of the area, but you just have to do it correctly. You can't just take them back in your pharmacy. This is just an example of some of these boxes. These are steel. They painted green here, but these are heavy duty, almost like safes. They're one way in. You can't get stuff back out once you put it in these drop boxes. They are locked. Ideally, you don't have, and you don't even want to have the key to these things. Okay? You have to have a third party, a disposal company that's certified, bonded, DEA registered, that can come and there's a sharps container basically inside, one of these poly containers that these things go in. They can slide that out. There is no inventory taken of that. You should not take an inventory. You just want to know that that numbered container is taken out of there, sealed, taken out of your pharmacy. They will have you sign some receipt that they picked it up, but you don't want to do anything to do with inventorying what might have been in there. Again, it could have sharps in there, definitely contaminated biohazard, things like that. So don't get involved in any of that. Other alternatives that are supported by that Drug Disposal Act are various types of things. I got a few examples here. I think we looked at a couple of them during class. You can't see this on district campuses, but this is one of the newer things. This is a little packet of powder that turns into a gel that you can actually pour into a prescription vial and add water to it, and it makes the drug where nobody else can take it. This bag is a similar thing that you just cut the top off, put liquid in it, and then pour the capsules or tablets in that, and it becomes a gel which prevents people from being able to take that. There's also mailers. Oh, I had a picture of a mailer too. Actually, that's what this is. This is a mailer like on a pegboard. It's at some of the pharmacies. This one's $3.99. These are free in Savannah. This is done by a drug disposal company that's based in Savannah. They make these plain white wrappers available to pharmacies in the area as a service to the community. And you can give those to a patient. They can throw their medication in here. And some people wonder, is that legal? I mean, again, it could be anything. Fentanyl patches, could be blood pressure medicine, anything like that. They seal it up, and it's post-paid, and it goes to this, actually goes to the postal office on Pham Street, but it's picked up by the drug disposal company. They don't open them or anything. They incinerate those things. It is legal. Is it completely safe? Well, I don't know. It's better than keeping them on your shelf at your house. You better believe that folks in the Postal Service and anybody else in Savannah knows that these bags probably contain used drugs and are being sent for disposal. But the idea is that is a legal way of people getting rid of these products. What they cannot do is bring it back to your pharmacy and you take it for them. Okay? You can give them some of these things. You can even help them go through the process of disposing of the drugs. But you cannot take possession of those drugs. Okay? Drug take-back days are held pretty regularly. They actually, the DEA sets these up nationally. So there's the same day that's a drug take-back day across the country. Their plan was to do those for a couple of years and then stop them. And they were going to stop them, and the problem was they kept having, they were so popular, people were still, coming, they have continued them. But they are not pharmacy events. You cannot schedule that at your pharmacy. Student organizations can't schedule that at one of these medicine clinics or anything like that. It is something that has to be administered by and supervised by law enforcement. Okay? So the few, and occasionally in Athens, there will be one out at the Walmart on the east side, and there is a police substation in that center, and they will set up in the Walmart. It is not the pharmacy at the Walmart. But again, patients, they got the drugs from you, they invariably think they can bring them back, and that is not the way to handle it. But there is a mechanism for doing that now, and you do get a lot of questions about that from patients that you'll have out there in the community. Going on with the miscellaneous rules, damaged products, we've talked about this as far as if your facility is involved in a fire, smoke damage, the sprinkler system goes off, any of those kind of things, you have to quarantine your pharmacy until you talk to the GDNA, and they will tell you, until we get out there and tell you can let anything go out of that pharmacy, you have to consider everything in your pharmacy as adulterated. I added this, not that I'm going to test you on it, but it doesn't just apply to drugs. It applies to all kinds of other things. Veterinary supplies, food, OTC products, all types of things. This is the way it should be handled through the Board of Pharmacy or the GDNA. You must contact them within 3 days. Again, you don't want to wait 3 days. That just gives you time if it's over a weekend or whatever. And they must respond within 3 days. They will show up at your facility. They will do an inspection and give you a written report. Until that time, everything is considered adulterated. They will determine whether the products are okay to be sold and enter commerce, or declare the whole thing as adulterated, in which case all the things you have there must be disposed of appropriately, and again, controlled substances and everything else. So it's a real bad thing to have. A couple other miscellaneous rules. This one kind of goes without saying. Deceptive advertising. The interesting, you can't use deceptive advertising practices. The interesting thing about this is actually a rule of the Board of Pharmacy. So if you do use misleading or deceptive advertising, you can get called before the board, things like that. Does it happen a lot? Not really, and we know people, and we know claims are made all the time that we don't think are appropriate. The FDA can follow up with it. This gives the Board of Pharmacy a chance to follow up with it, and they do every one. Theft, loss, we talked about this before, of unaccounted for controlled substances. Don't just limit it to controlled substances. If you have drugs stolen in your pharmacy, it needs to be reported to the GDNA and Board of Pharmacy and local law enforcement. Okay? So they can be on the watch in case people will come, groups of burglars will come to an area and they'll hit one pharmacy after another, night after night. So don't keep it a secret. Yeah, you definitely need to let your local folks know as well. We talked about one of the relatively few number of forms I want you to know about. Form 106 is the accounting form for theft or loss of controlled substances. It's a DEA form. It definitely goes to DEA, but it also needs to go to the GDNA, the Georgia Drugs and Narcotics Agency, so they know about it. I'm going to skip really kind of through this. Release of confidential information, that's what the Georgia Board of Pharmacy calls HIPAA. Regulations, y'all know all about that. We talked about it specifically. My different take on it, maybe than you got in other classes, is to don't use HIPAA as a reason not to give good pharmacy services. Don't say I can't talk to you about your parents or your you're a caretaker, your patient's drugs or your child's drugs or anything like that. Saying, well, I can't do that because it's HIPAA. Know what you can do and what you can't do. The biggest thing, here's some lists here as far as people you can provide release to, definitely, or release information to, definitely the patient, their authorized representative that's been told to you in writing, the prescriber, for sure, another pharmacist for transfer, but not just talking with another pharmacist, about the medication somebody's on. Okay, that would be inappropriate, but for purposes of transfer or actual medical care, consult or whatever, it's definitely legit. Definitely the board, put that in capitalization, realize they can come in and look at, take, seal up, take off site, whatever, anything in your pharmacy, and authorize law enforcement. definitely GDNA and DEA without question, Medicaid agents, federal agents, things like that. Be careful as far as local law enforcement. You definitely want to cooperate with local law enforcement. This is in Duke's opinion here. I think you definitely want to cooperate with them, but they can't come in and do what the GDNA refers to as a fishing expedition. They can't come in and just go through your files and see what doctor's writing certain prescriptions or see what patients are getting certain kind of medication. The GDNA, technically they can, but they're only going to do it appropriately. They might be checking up on a prescriber in the area and want to see your C2 file and see who's writing all these things. That would be appropriate for the job they do. For local law enforcement, that is not the case. They need to be specific. It needs to be in direct association with a case that's under investigation. If there's reason to think there's potential harm to the community or individuals, or they have a subpoena or court order. Those would be the only time. The other thing I just want to reiterate as far as children, minor children, the parents definitely have a right to know what those minor children are on, unless you've heard otherwise. The only way you hear otherwise is if a minor child says, I specifically, am talking to you and I don't want you to talk to my parents about this medication. Then it becomes, they are protected by HIPAA. Prior to that time, minor children, it is appropriate for their parents to know the medication history and what they're on. Caution, watch out for those fancy looking letters, fancy letterheads from attorneys, subpoenaing information for this patient, or likely, frequently, it's the spouse of a patient who they represent, all that stuff gets kind of ugly. There is a chance that you would give that out, but only with a subpoena or court order, not on the order of an attorney representing a patient or a patient's family. And the key thing, this last thing, a key thing, is that your pharmacist, if you follow these provisions based on the Georgia Board of Pharmacy rules, you are protected. And again, remember the Board of Pharmacy is the affiliate. They're empowered by the state legislature. So they say if you follow these rules, you're protected from further action, lawsuits, things like that. It doesn't mean you can't be sued, but it means that they can't find against you if you follow these provisions. Speaking of the Georgia legislature, today is supposed to be Sine Die, should be the last day of the session this year. If anybody's bored tonight near midnight, if you pull up on the legislative site that lawmakers, Georgia Public Broadcasting lawmakers, where they have it live, it gets kind of interesting. They're around midnight. Hopefully y'all have better things to do at midnight tonight than look on the web for what's happening at the state legislature. But they will be going until midnight, usually shortly thereafter, and then everything will be done. I'll send you a follow-up as far as the legislation that might pertain to pharmacy. The big news, of course, was the anti-steering bills were passed. Actually, somebody had asked, and I didn't have a chance to follow up with students here, when that would go into effect. And so it depends on how the legislation is written. I actually looked at those today. Both of those are written not to take effect at the signature of the governor, as many of them are written. These are not to take effect until January 1 of 2020. So it won't be until next January that those will go into effect. Okay, going on, finally getting out of those miscellaneous rules. This is similar to something else we've talked about. This specifically applies to nurses that are practicing out in the community, employed by home health care agencies. These people do a lot of things. My dad has nurses that come and see him at the house and do numerous things. Many of the things they do as far as administering drugs, they have to have a physician's order, obviously, to put a patient on an antibiotic, or to start an IV antibiotic, or something like that. However, in order to start an IV antibiotic, if that's ordered, they have to have some other things to get the IV started. So this is kind of like an emergency kit, very similar to the EMS kits we talked about, very similar to even the crash parts emergency kits in the health system. Just a slight difference, but it's another place where people have access to medications without specific order. This is for nurses that are doing this on a home health care basis. They're referred to as sterile drug maintenance kits. It's basically the things they need to start an IV, to change an IV, or to change out an IV site on a patient, so that they don't have to have a specific drug or drug order prescription because it would keep them from being able to get this done on a reasonable basis. For any component they use, if they don't have a patient-specific prescription, again, they have 72 hours to report that they have used that drug. And usually the idea there is they have to bring the kit to you, report what's been used, you restock it with everything, check the expiration dates and all that stuff, and reissue it to them. So they will have it for the next patient they use. Now they might have enough in that kit to do 2 or 3 IV changes or things like that. Again, it depends on the policy and procedure you have set up with them. But the pharmacy, whether it's at a health system, whether it's a community pharmacy practice, or you're providing it through some other pharmacy service, EIC does have responsibility, again, for the record keeping, for making sure that the kit is sealed and that people can't just take medications out of it, put them back in there without it going through you, and making sure that everything in there is supposed to be in there, that has appropriate expiration and all that. And it must be inspected monthly. So somewhere along the way, they've got to take it to the pharmacy at least monthly to make sure that everything is in date. But again, if they're using it pretty regularly, the key thing there is they come to you to get them restocked. Okay? So again, this is very similar to the EMS kits, even the emergency kits. There'll be one more category we'll talk about before we finish up as far as things like this that are provided to people that need them on a real-time basis. Even if this is not an emergency, but it's just in order to do the job they're trying to do out there, they have to have those medications. They can't stop and get a prescription every time they need another bottle of sterile saline, even though those do have the federal caution. Okay, the next thing is kind of a more recent, it's been around a long time, but it's a more recent type of registration or pharmacy. And so it wasn't up there with all these other pharmacy license types we talked about earlier on in the board regs. This one is the opioid treatment program, or opioid treatment pharmacy. There's about 60 of these licensed in the state of Georgia, so you may go through your whole practice and never work with one. But they are out there. It is a career opportunity for pharmacists. A lot of these provide part-time opportunities. So I know pharmacists that have full-time jobs, or maybe had a full-time job and got out of it, to have a family or whatever, and they work part-time. So there are some very specific requirements. It is one of the few areas that they again call the EIC a director of the opioid clinic pharmacy. I'm not going to test you on that. I think that's that important. The key thing is just to know that that person is the pharmacist in charge, so they're the one responsible for all of the medication used in that facility. Again, a lot of times they're part-time jobs, so the pharmacist may be absent. There are ways that they can, have a policy and procedure to have prepackaged drugs, have trained personnel as far as who can check those out in the absence of a pharmacist. One of the frequent type of opioid clinic pharmacies are methadone clinics. And there's a number of those here in the Savannah community. I know there's a lot of them around the metro Atlanta community. Again, the ideal thing there is that they use liquid methadone at a certain concentration per ml, and the dose is very specific to the patient. So the pharmacist spends a lot of time working along with tech dispensing those. And in those cases, a lot of times it's very restrictive as far as they can only release medication when the pharmacist is actually there. If you get involved in that kind of practice, one of the main things to check on is who is your prescriber. It can't be just any physician in the community. They have to be specifically certified, and they are hired by the opioid clinic treatment facility itself. Sometimes they own the treatment facility, so make sure everything's on the up and up there, that they are actually board certified in addiction treatment and allowed to prescribe those medications. Remember, we said specifically something like methadone, frequently used now as a pain med, and it is appropriate for people to prescribe it as a pain med, but if someone is going to prescribe it for addiction treatment or supporting an addicted patient through a withdrawal process, they have to be specifically board certified in addiction treatment. It's not okay for just a regular MD to prescribe addiction management therapy. They have to have that special board certification. Okay, jumping on along, and again, this is just based on how the regulations come up in the listing there on the board website. We talked about this before, exempt OTC, Schedule 5 controlled substance. The big deal about that in Georgia is there's two types. There's pseudoephedrine C5s that don't require prescription, and then there's non-pseudoephedrine C5. Most of the non-pseudoephedrine is going to be your cough syrup. It contains a small amount of codeine. I always put it this way in quotes, that cough syrup you have to sign for. That is the one that is the main drug that's not pseudoephedrine product. Again, realize that the pseudoephedrine handling of that as a C5 is specific to the state of Georgia. We're not the only state that does that, but a lot of states that comply with the federal regulations do it in ways other than making it a C5 pharmaceutical drug. None of those have federal caution on them. Some states have gone further and actually require prescriptions for pseudoephedrine-containing products. Sometimes even within a state that doesn't require a prescription, there might be a community that actually went to that extra level and requires it to be prescription only. That's important to know if you are practicing in another state or getting ready to go to a residency in another state. You have to get those specific things on a state-by-state basis. The unique thing about Georgia is they do make it a C5, and so that kind of helps you know what's going to be required. In general, for Schedule 5s, a logbook is required. You used to have a logbook for pseudoephedrine and a logbook for cough syrup. A lot of times you don't have a logbook now for pseudoephedrine, as we'll see in just a few minutes, because we have to keep up with that. We have to track that with that electronic register. Okay, and that can replace the logbook. You have to have both. Pharmacist or intern only here means who can dispense that, who can make the decision to dispense that at the request of a patient. Not your clerk out front, not your tech that's worked there maybe longer than the pharmacist has. The decision has to be made by a pharmacist or an intern under the direct supervision of a pharmacist, and stated in the reg there, it says they must make a reasonable attempt to determine that it's for a legitimate medical purpose. Okay? This is basically for pseudoephedrine and for that cough syrup. It's just not automatic. Somebody always gets it here. Again, the pharmacist or intern under direct supervision should make the decision to dispense that or not. As far as logbook requirements, specifically it says the purchaser is to sign it, put in there their date of birth, address, city, state, zip, and then the pharmacist will include the date, name of product, quantity, and intended use. Again, that's a column in that logbook. If you're making your own logbook, go to the regulation and see what all types of things have to be kept up with. And again, this logbook is still required for the cough syrup. For non-pseudoephedrine products, here are the limitations. It's relatively easy. 4 ounces of liquid or 32 dosage units in a 48-hour period. And this only pertains to C5s that don't have the federal caution or prescription only. Okay? A lot of you work in pharmacy all the time. You know there's plenty of other C5s that actually have the federal caution on them. You can't dispense them without a prescription. If it has that on there, things like Lomotil. Okay, it's one of the ones I think of right off the bat. But anyway, so make sure if it's one that you think you're going to be able to dispense just by having a patient sign for it, that it doesn't have the federal caution on it. Like say in Georgia, there's very specific differences between pseudoephedrine or non-pseudoephedrine exempt narcotics or Schedule 5 or exempt OTC. All those are names for this category of drugs. Based on the combat methamphetamine law, which is federal regulation, it is now required that you check a state-issued official ID prior to dispensing pseudoephedrine. It doesn't say you've got to make a copy of it. It doesn't say you've got to write anything down. It just says you must verify that the patient, the person requesting it, has a valid ID. There is now, at the federal level, the requirement to have an online database. It must be entered in that. Again, the C5 category is specific to Georgia. Federal regulation does not make pseudoephedrine C5. Okay, Georgia went that extra level as a way of controlling it on their part. But we now must register sales online, which can be shared. You can basically check that and see if the patient's got any others at the time you are selling it, and must show you that ID. I put this in here just to remind you again, the easiest way, there's a whole pages and pages list in this regulation that frequently when a pharmacy that I'm working in says, now how much of this can we sell? We'll just print that part out from the website and tape it on the wall, the shelf right behind the drugs. But the easy way to do that is just stick with the commercially available containers. If you do that, you're not going to go outside the law. There is a difference depending on whether the pseudoephedrine is hydrochloride or whether it's sulfate as far as how many grams or milligrams can be sold over a certain period of time. So the easiest thing is to either check that listing on the Board of Pharmacy website, contain, or stick with your commercially available containers and don't let people buy 12 of those at a time. Okay, I think we hit that one several times, probably about 3 times, so you can be sure some of that's going to be on the final exam. I'm about 10 questions away from finishing the final. I'll plan to have that done by Thursday. And at the beginning of class, to make sure I don't cut off at the end, we'll go through that and kind of give you an idea of what sections or what subject matter is covered on questions on the final. Okay, so you'll have, it's a lot of material anyway, but it may help you kind of focus on things like, ooh, I didn't get that much the first time, I'll go back and look at that again. We'll do that at the beginning of class on Thursday, but we have right after class meeting before the final. Okay, the next section again is a newer type of pharmacy, and the ones that are listed at the beginning of the regulations, it's just where they added to the numbering system of the regulation. This is a retail pharmacy which also provides home health care service. Frequently that includes home IVs and things like that. Remember we talked about the specific requirements for a PIC. You don't be PIC in one pharmacy at a time, except in that narrow situation when you're under one roof and you're operating 2 different types of services. One of which could have been home health care services, the other one could have been serving long-term care facilities. This basically combines the divisions of a community pharmacy practice with a compounding, sterile product compounding pharmacy. Somebody that's going to make IVs for home use. Again, when I leave the rest of it, that means it's not important. The blue part is the part I want to emphasize. So you kind of read through all that as you're going through your studying. It does require a PIC, talks about having appropriate supportive personnel, secretarial, whatever. In the staffing requirements, one of the main things that probably ought to be in blue is a licensed pharmacist should be accessible at all times. This means somebody on call that can answer questions. If a caregiver at the home has a refrigerator full of IVs, and there's maybe 2 different drugs, and they forgot which one the next one to hang on that patient, they should be able to call a pharmacist, not just a tech, and get you to respond and be able to check the profile and let them know answers to their questions as that time goes on. Going to skip the rest of the stuff pretty quick here because basically it's the same things we talked about as far as the home use sterile drugs. Okay? This specific type just means that this person is also operating a community pharmacy practice. Key things are making sure there's policies and procedures for what to do. There's training manuals and you document training when you train your techs to use appropriate sterile techniques and how they check for sterility of the pharmaceuticals or compounds, things like that. Must have a separate area for sterile compounding. Again, that's the clean room, and sterile USP 797 handles all that. They have minimum space requirement, 150 square feet. And all of this equipment, they go through specifically talking about things that have to be there. All the equipment you would need to do this type of pharmacy practice. Okay. Prescription drug orders filed by patient or serial number. A little different filing system, but it makes sense in this kind of practice. You actually have a patient medical record, so you don't have to necessarily pick up everything by serial number. Something that is unique to this type of pharmacy practice, unique to this in health system or hospital practice, is that in addition to the prescription record, you have to have a patient profile, where you have information that might not be contained on this individual prescription. Again, because of the kind of care you're providing in this case, it kind of makes sense that you would have this, but it is one of the few other areas that require specifically a patient profile. In traditional community practice, a lot of this comes under over 90, and the DUE and checking for interactions, drug food, drugs, all those interactions means that you have to have a patient record. But specifically for this type of pharmacy, it's required that you have a patient profile in addition to your listing of drugs that sends to that patient's home, wherever they're being taken care of. Other records, same as everybody else, including that biennial controlled substance inventory. If you have cytotoxic materials, and again, this might come into play with that USP 800 of hazardous materials. There's a policy and procedure for how you have to handle disposal, spills, chemical spills, things like this, because of the nature of these drugs are different than just, spilling a bottle of tablet on it. Okay? Delivery requirements, it's the pharmacist in charge responsibility, again, not only to get the patient, the medication filled correctly in the pharmacy and have it ready for pickup, but a lot of times in this case, we're delivering these to the home, okay? Home health care. They can't come out and get the drugs, we're going to take it to them. So you're definitely responsible in transit and all the way until it's stored appropriately in the patient's home. So it's not enough if you're delivering IV medication just to get it to the front door, ring the doorbell, and go and make the next delivery. Those medications, as far as to have the shelf life that they're listed as, should be, if they're required to be stored in the refrigeration, you got to make sure they get all the way to where they're supposed to be stored, into that refrigerator or whatever appropriate storage area for those medications. And that's, again, unique to this because of the type of practice they're involved in home health care. Mentioned already, cytotoxic agents require some additional requirements because of the chance that not only could they be hazardous to the patient, but they could be hazardous to people working in your pharmacy. You have to have appropriate training, precautions, and ways of handling it. Again, still talking about that home health care pharmacy. You're filling the medications, you've got techs filling the IV, and make sure you're getting orders from the physician, and then you know where these go, and you're having your delivery people go out and place them appropriately and do all the things they're supposed to do. That's great, but there's still a requirement you must contact that patient and have a pharmacist-patient contact at least quarterly. Okay? Not every time and not once a month, but at least quarterly. Doesn't even say for sure you have to go out there, but again, it's required. This pharmacist-patient relationship verification, which should be just part of good pharmacy practice, but they specifically add that in there that at least quarterly you need to check up on what's going on with this patient, that things are still the same at home, and their storage facilities are available, and refrigerators are working, and all those kind of things. It's responsible for the pharmacist to document that in the profile that they're doing that, at least quarterly. Again, all this goes along just like the home health care and sterile compounding we did before. Something kind of unique here. We talk a lot about expiration dates and beyond use dates. As far as compounding, we talk about it as far as repackaging products, all those kind of things. Again, this is kind of unique here. If you're compounding sterile products for home use, anything that you have labeled that has greater than a 10-day expiration, you need to have additional backup to show that you either tested this in-house and you have published data to support that it is stable for that length of time. Again, you're sometimes mixing multiple drugs into IV solutions, not really sure, again, you're supposed to make sure you know where they're stored, but there's some concern as far as how they're stored in the patient's home. Anything you put on there that can be used for longer than 10 days, or more than 10 days after you deliver it, you need to make sure you have data to back up its stability. Okay, that's a couple more types of licenses we'll cover if we finish on through that, but that's kind of wrapping up the different types of pharmacy practices. Again, this was kind of a hybrid of two others that we've already talked about. We get back into the requirements of prescription drug orders. It's spelled like under order or something like that in the regulations. So again, you want to read through that and get the full verbiage. This will be reviewed over what we talked about before. We talked about, in fact, when we were covering the federal guidelines as far as what's required for potentially dangerous drugs and controlled substances. We're going to do this pretty quick. Key thing never to do is to fill a controlled substance prescription for office use. Okay? That is not an appropriate way for a prescriber's office to obtain controlled substances for use within their facility, their clinic, or their doctor's office, or whatever. They have to get them from a wholesaler, go through the whole process of verifying their DEA registration, just like you do. So they cannot come in and write a prescription for Lortab, or Valium, or Lexapro, or anything like that, to get a whole bottle of those they can use for office use. Okay? Only way you can dispense a controlled substance is on a patient-specific prescription. Okay, what has to be on that prescription? Again, these are those lists that hopefully you all know pretty much automatically going through labs. A lot of you work a lot and see this all the time. It does require the practitioner's name, address, telephone number, DEA number, if it's a controlled substance, be on that. And these are controlled substances, be on that prescription. It should be signed and dated on the same day that it's issued. And this gets back into that. We'll talk in a minute about C2s written for future filling. You don't post-date prescriptions. They have to be dated for the day they're written, on the day they're written, not the date that's supposed to be filled. Okay? If they want it filled at some time in the future, they write that separately, but it still needs to have a valid date that the prescription is actually written, or it's not a valid prescription. At the time of dispensing, this is where they add that in. The name and address of the patient has to be on the prescription. This covers the situation where frequently they'll put the date of birth on there, but they hardly ever put the patient's address on there. But if you have it in your database, if you add it to the prescription at the time of dispensing, you're in compliance. Signature, remember there's no rubber stamping. It must be signed as a check or legal document by the prescriber. That person that signs that prescription is their prescription. It doesn't matter how many other hands it's passed through, or who's added a note to it, or written out part of it. It's the person that signs it who it's their prescription. If it's a fax, where it gets kind of specific, it could be either an original signature or a visual image of that signature, a JPEG file or something like that. Electronic prescribing, again, remember this is a controlled substance. It can be either the visual image signature or electronic data signature. And that's the one that's just a string of letters and numbers. That's specific to electronic prescribing that comes through, you know, the service in the middle. Basically, it's SureScript. I think of a generic name for that. But the data adjudicator that's sent from the physician's office, it goes through them and it comes to your pharmacy. Okay? The format. That would be like, in most cases, it's SureScript. Preparation of the prescription for signature, sure, anybody can do that. Patient can do that. I wouldn't recommend it, but it has to be done by a practitioner's authorized agent, so they can authorize pretty much anybody they want to be ascribed to them. And then they are responsible for all, and it contains all the information that's required on there. They're the ones that sign it. It's their license. It has to be their DEA registration. Again, we're talking about a controlled substance. Anytime you see something that says somebody is using someone else's DEA number, that's probably not the answer. Okay? And that's been on every test so far. Probably we'll see that on the final. Nobody can use anybody else's DEA number. Okay? The DEA number for authorized prescription has to be the person that signs it, and it is that person's prescription. Okay? I don't care if a nurse practitioner or PA wrote everything down and hands it to the prescriber. If they sign it, it becomes that signer's prescription, not the nurse practitioner. Okay, we talked about this before too. Special case for DEA numbers for people that are working under a health system DEA number. Kind of like the way it works for pharmacists. We don't have to have our own DEA number. We use the DEA number of the facility that we're licensed in. Same thing for staff, house staff, residents, the new and increasing number of hospitalists. It can be a hospitalist physician. It can be hospitalist, nurse practitioners, PAs. They won't necessarily have their own DEA number. They will be assigned by the health system a suffix to add to the hospital DEA number. That is their official DEA number. It actually says in that case that this will actually be on the prescription. I have never seen that happen, but it's actually in the law, it's in the regulation. They'll have the name of the practitioner stamped, typed, or hand printed on it, as well as the signature of the practitioner, along with a telephone number where that practitioner needs to be contacted for verification. If anybody gets one like that, you call them. Take a picture of it, take the patient name off of it, and I'll say, here's one example of that. That never happens. The problem this creates, especially when house staff change over on an annual basis in a health system, you'll have some signature. You won't necessarily have the name stamped, typed, or hand printed on it of the person. And they will have this DEA number, that's the hospital DEA number, -011. Okay? That's their DEA number. You can't match up with their last name or anything like that. So, and who are you going to call? you're going to call the hospital number, and you're going to get the same number that everybody calls to check on a patient. And basically, you're going to round robin. Nobody's going to be able to get that information. Frequently, if it's being written in a emergency room, you can at least call the emergency room and talk to somebody there and say, hey, I got this prescription, I got a number, but I don't know who this prescriber is. Used to be we could just put in the name of the health system, submit it on through, insurance would pay, all that stuff. That doesn't happen anymore. So you have to have the correct name, and you're going to have to track that down. But it's actually in the Board of Pharmacy regulations that that information has to be on there in addition to that telephone number to contact. Again, I've never seen it. Somebody let me know if you ever see one. Okay, board review requirements of the C2 prescription drug order. Remember, there were several different categories. First thing we talked about were the emergency prescriptions. Y'all get those all the time. They should be really for an emergency, and they should be just for the amount to cover that emergency period. What we all know happens is it becomes an emergency because somebody forgot to go by the doctor's office and pick it up, or didn't pick it up while they were there, or they just decided they need it now, and the doctor's office, calls it into you and says, you've got to call an emergency prescription with C2. It shouldn't be done on a regular basis, but we all know it is. It is supposed to be only for the emergency period, not for 30 days or 90 days or whatever. And again, they call it in that way all the time. But based on the regulations, it should only be to cover that emergency period, which means until the patient can go get a real hard copy prescription. They do have to follow up with a hard copy within 7 days. Postmark within 7 days, that's fine. But do check up on that. Don't end up with a stack of prescriptions, emergency prescriptions that, you put in a little file box, put up on that shelf in your pharmacy, saying, okay, we'll wait until the physician's office sends this prescription, and then the GBNA agent comes in, and you've got a stack of these things that are months old. You will be in trouble for that. So do follow up with them and make sure they do follow up with you. And, be forceful on that. Maybe next time they'll make sure they give the patient the hard copy to start with, rather than have to go through all that. You do have to make sure you match those up with a hard copy. People think this is a trick question. Really, it's not. It's a real thing out there. And some people will be working in a practice, particularly you have a lot of hospice patients, where you might get C2 prescriptions faxed in. That is different than the previous case we talked about. That's not an emergency prescription. It has to be followed up with a hard copy. You can actually use the fax as the original in 3 cases. Patients under the care of hospice, long-term care facilities, or terminally ill. It does need to be noted on the prescription. In fact, they apply to one of these areas, and one of these areas is correct, so that you can use that fax as an original, and you don't have to follow up with a hard copy otherwise. Okay? Refilling, when can you refill a C2 prescription? Never, never, never. Okay? Pharmacist requirements when filling a prescription, you must sign and date it. Not your initial, not take your signature and date it. It can be on the front and back. Most of the time people have it on the front. I just found out, I think I may have mentioned the case that where somebody filled the wrong strength of fentanyl patch, had problems with the patient. They've been on 25 micrograms for months, and it was filled this month with 75 micrograms. The patient had a problem. Prescription very clearly says it's for 25. And the lawyer involved in the case, after we talked about it, he said, well, how could this happen? I said, well, here's how it happened. You get the prescription in, the pharmacist looks at it and decides, okay, we know this patient, we do have this drug, we are going to fill it. They give it to the tech punches it into the computer, punches it in 75 micrograms. Then the label comes out, prescription, everything looks, the prescription label and the paperwork looks right for 75 micrograms. The only thing that still says 25 is that paper copy of the prescription. They turn that over, stick that label on there. Somewhere along the way, nobody ever turned that prescription back over, or at least didn't read it and turned it back over, and filled it, and patient lived, but it's going to be a problem for that pharmacy. Okay, partial filling of C2s, a little more complicated. Remember, we have that 72-hour rule. We have a lot of those. If you are short of the medication and can't supply the whole amount, you can say, look, I can fill enough to get you through, 2 or 3 days, and we'll have the others in tomorrow or within 72 hours. Patient says that's fine, we'll take these now, we'll come back and get the others. Again, you're not doing it, you're not dispensing the full amount because you don't have it available. Be careful about getting thrown out by the patient or the person getting the medication saying, hey, doc, I don't quite have enough for all 120 of these hydrocodone 5-325 right now, but mom or dad or grandma, they really need these. Can I get like 20 now? I'll come back tomorrow with the rest of the money. It's always cash pay patients. This happens to, of course. And be careful. Could be legitimate, probably not. Probably trying to get those medications so they go out and sell them, and then come back with plenty of money and pay you for the rest. Don't get caught in that kind of situation. It's up to your discretion. They only talk about not being able to fill it because of supply. Again, if you know you've got 5 patients on this and you only have one bottle of 100 left, well, you might actually have enough to fill that prescription, but you're going to need those down the road. It is legitimate for you to say, we're getting some more of this in tomorrow. I can fill a portion of this now and fill the rest. But you need to come back and pick them up within 72 hours. It can't just be sitting there in the ready bin. It must be delivered in their hand within 72 hours or the rest of the prescription expires. Okay? The exceptions, remember we always have to focus on those. Again, those same three categories: long-term care, terminally ill, or hospice patient, identified on the face of the prescription. You can partial fill those and fill remainder parts of it based on the type of medication distribution system that is being handled by the long-term care facility, the terminally ill patient's home, or the hospice. Okay, it's mainly for a safety thing. Rather than having a 90-day supply on hand, it is fine. You dispense those a week at a time, or 15 days at a time, or 30 days at a time in those specific cases. Anybody else, 72-hour rule applies. They get the rest of it within 72 hours, and the rest of the prescription expires. Okay, we mentioned earlier the sequential prescriptions for C2s. The problem there is a lot of prescribers who are authorized to do this don't know how to do that. They will post-date a prescription. They'll write one for April 2nd. They'll write one, and the only date on there will be May 2nd. They'll write another one and have June 2nd on it, under the date, which should be the date that it's written. That is not the way to do this. Okay? They must date it on the date that it's written. Date them all for April 2nd. And one of them could be filled today. On the next one, they write, do not fill before May 2nd. On the next one, they write, do not fill before June 2nd. And they might give you all the prescriptions at one time. It's up to you as far as whether you profile all those, or whether you say, I only want one at a time, or you put them in another pile, or however you want to do it. But you can't fill it before that date that's stated on it. A lot of discussion comes up as far as, well, the pharmacy I'm in is not open on Saturday. They're not open on Sunday, as the date is written for that day. GDNA will tell you when the prescriber writes on there, do not fill before that date, you don't have any wiggle room on it. Do people make variations in that? Yes, all the time. But it is not in the regulations saying. However, you can fill it up to 48 hours or 3 days ahead or 24 hours ahead or anything like that. Nothing in the regulations about that. Okay, I suspect that's going to bother some of y'all, and I'm glad to talk to you more about that. Drop an email, we'll talk about it. Again, for these sequential prescriptions, it's not automatic that it be month by month by month. They can write them any way they want to. The thing is, they can't write more prescriptions at one time than to cover 90 days. Okay? They can write 6 prescriptions for 15 days worth. They can write 3 to 30 days worth. They can do any combination of those things. But they can't write that many ahead of time to cover more than 90 days. Okay? Okay, shifting now to non-C2s, 3, 4, and 5. Again, these are the prescriptions that do actually expire 6 months after the date they are written, not 6 months after the date they are first filled. They can have a maximum of 5 full refills. We'll talk about partial filling, you can partially fill that up to a full refill, again, not getting ahead of the schedule as if you filled them a full refill each time. So, trying to explain that, if somebody comes in and says, I only want to get 15 days supply, great, then you get 15 days supply. They come back at 15 days and get the rest of that 30-day supply. But they come back 30 days and they say, well, I actually got more money now, I want to go ahead and get my next month. Because you can't fill that. If they got 30 to start with, 30-day supply, you wouldn't be able to fill that before the next refill was due. don't get ahead of that by filling 15 and then 30, which would put you into the middle of the following month. Okay? If the refills aren't on there, and the prescriber can add refills. We used to do this a lot more before we had electronic prescribing. Now they just write a new prescription. They can add refills up to 5 within the original 6 months. Alternatively, this is what usually happens, they either call in or electronically send you a new prescription that might have some additional refills on it. Labeling of controlled substance orders is the same as for dangerous drugs. Remember what dangerous drugs are, all those other legend drugs or prescription-only medications that aren't controlled. Plus, they have to have that federal caution on there. The federal caution is that thing that's frequently just pre-printed on every label that you have. So, naturally, sometimes people just think, well, that's just required to be on all prescriptions. It's not. It's only required to be on controlled substances. It's okay to put it on others. But basically, it's printed so small you can't even really read it. But it says that federal law prohibits the transfer of that patient to a person other than the person prescribed to. So it is not okay for somebody to say, hey, I got some hydrocodone. If you try that for your back, you can try some of these. Federal law prohibits that. Okay? If they come in and say, well, I got to get my prescription filled early because I had to give my spouse, my hydrocodone, that is not okay. It's on every one of those, should be on every controlled substance prescription you dispense. Transfer requirement, I've got this several times, so just think of this as underlining it. Definitely something that's important for you to know for the exams, definitely for practice. In Georgia, it can only be between pharmacists, interns, and externs. Okay, no tech can do transfers only once for controlled substances, unless that pharmacy shares a common database. They can transfer it basically within that chain. It can see where it was dispensed at other locations of that company's pharmacy, up to the maximum number of prescriptions allowed based on the refill. It's actually in the law 2 different places. One place only says it can be done once. Then when it talks about electronic prescriptions, it will say the exception of allowing it to be transferred as long as they're sharing a common data. Basically, that just keeps it to the same drugstore. That might sound like a little unfair competition there for independents, but that's what the board allows. If someone is sharing a common database, they can see that it was dispensed just as well as you can see dispensed on your own individual computer if you're an independent or if you're another chain. Okay, you can't go back and forth between 2 chains, even though they're sharing common databases in their chains, they can't see each other's statistics. So the whole purpose of this is basically to keep somebody from swim planning and get more than their allowed refills by getting transferred to another pharmacy, get the maximum number of refills there, going back to that original pharmacy, get the maximum number of refills there. So again, don't get caught by pharmacists or by patients trying to be tricky with that. Specific requirements as far as the information has to go back and forth for the transferring pharmacy. You definitely need the name of the person you're transferring it to, the date, and information on there. You need the DEA number of that pharmacy. For the receiving pharmacy, you have to have all the information that you would need if it was a new prescription coming to you, but you also need original date filled and last filled, so you know how many of the original refills are still remaining. You need the pharmacy name, address, phone number, and their prescription number of the pharmacy that you're getting it from. You can do electronic transfers. Most of the time that's going to be between pharmacies in the same chain, but again, that would have the same requirements. You can get, if you're calling a pharmacy and you're getting a patient's whole profile, it's definitely okay to get them to fax that information electronically or by paper fax to you. Again, as long as you have all the same information that's required there in order to fill it in the prescription. Okay, prescribing requirements for PAs and APRNs. Remember, that's APRN, the official name in Georgia, Advanced Practice Registered Nurse, or what we refer to as a nurse practitioner. But for purposes of regulations in Georgia, both for the nursing board, medical board, and pharmacy, they call them APRN. Okay, and this is a kind of disclaimer that allows us to fill a nurse practitioner or PA prescription without having to call on every new person in town, as long as we feel like it's a legitimate prescriber-patient relationship. Again, as long as you follow those regulations, not to be held responsible for that. You cannot fill a nurse practitioner or PA prescription out of state because the rules vary from state to state, and Georgia just handled it by saying none of their prescriptions are valid in the state of Georgia. They have to have a Georgia license and have all their nurse protocol, PA job description, and everything with their prescriber licensed in the state of Georgia in order to be able to write prescriptions in the state of Georgia. Additional requirements on their prescriptions, because it came later in the process when we had added this additional identifier, NPI number, National Provider Identifier. It is required that you have the National Prescriber Identifier number on a prescription from a nurse practitioner or PA. There is a limit on their dangerous drug refills to 12 months. Their prescriptions for dangerous drugs do actually expire after 12 months. This is what we tell everybody about every prescription, but realize if it's written by a licensed prescriber, that is not the case. The only ones of their prescriptions that expire are control 3, 4, and 5. They expire in 6 months, or after their 5 refills, whichever comes first. And notice I didn't say C2s. C2s written by licensed prescribers. Nurse practitioners, PAs can't write C2s in Georgia. So people that write C2 prescriptions, technically their prescriptions do not expire. The 12-month thing comes from our third-party plans, and we tell people it's law. It's not the law, but it's third-party law. It's not still regulation, but basically it's not going to get paid for after 12 months. And not that it's not a good idea for them to go back and see their prescriber every 12 months, but just realize it's not the law that prescription expires after 12 months unless it's a nurse practitioner or PA. I'm not going to ask you that. I don't know where that comes. Most nurse practitioners and PAs don't even know that. For oral contraceptives and prenatal vitamins and things like that for nurse practitioners, those prescriptions actually go for 24 months. 12 months is usually plenty for those things. Okay. Prescription drug samples. We talked about this. We talked about the Dingle Amendment. We talked about Rick Allen and the whole Harmonies sting operation they did. They got all these drug samples that were being rerouted into distribution, were showing up in pharmacies and being sold. Patients, illegal. So because of all that, especially in Georgia, because of the involvement of our DGNA and exposing this nationwide, never in a pharmacy can you have prescription drug samples. Okay? They've gotten around this by having those plastic coupons that you have to run through like a third-party thing to give people, trial supplies and things like that. So it's created another nightmare for us. But we do not get prescription drug samples. Do not accept prescription drug samples from a practitioner who wants to pay their bill or order some medications from you and hey, I'll pay you back in drug samples. And the idea that you could sell those for money, do not get into that. That is totally illegal and all kinds of trouble. The practitioners who may receive samples, licensed prescribers, including APRNs and PA, mid-level practitioners in the state of Georgia, they can get samples from manufacturers and dispense them to the patient. If it happens to be a drug that's a controlled substance, they have to be appropriately DEA registered, but otherwise, the manufacturers, they supply them to them as samples with the requirements they have for prescription samples. It has tightened up a lot since all that legislation went through. In the Prescription Drug Marketing Act, there are specific requirements. Before that time, it was wide open. They sent these things to detail people. They stocked them in their houses and apartments. They carried them around in the trunk of their car, and they gave them out like candy to prescribers to get them to start writing their prescriptions. But there are requirements now. Most of the time, they have to fill out a card and send it back directly to the manufacturer and have those shipped. A lot of times, the detail person or drug marketing people are not even involved in actually handling samples because too much of this was going astray and finding its way back into the legitimate supply chain. Practitioners that receive samples have to keep records at pharmacies. So all the drug samples they request and receive, they have to list specific number and dosage of those samples, and they have to keep a list of who they give them to. Okay? Now it can be kept in the patient record. Doesn't require a separate prescription file for dispensing samples. We will see some specific regulations as far as prescribers who dispense medications to their patients for money, and they are required to keep the same kind of records that a pharmacy. including prescription drug files. But for samples, they must keep up with who they go to, how many they give them, and who the patients are that get them. They always do that? Probably not, but it is specifically required and written in pharmacy regulations that prescription drug samples have to be controlled that way. And just like everything else, almost everything else in the Georgia regs, it requires them to keep those records for 2 years so they can go back and determine if things were used inappropriately from that prescriber's office. Okay, kind of fast and furious there, but again, a lot of that was reviewed. Don't take that as meaning it's not important. It probably means that stuff that is important. Think of it as underlining it. You're probably going to see it on the final exam. Got one more section of notes which I have posted. So we're within 5 minutes. I know we got cut off last time, so I'm just going to stop there. Talk with you more on Thursday. Like I say, we'll start off going over the types of questions that are going to be on the final exam to kind of help you with a little bit of a study guide type of operation. And then we'll go through that last section of notes, and then we'll be done. We've got next week off until Thursday. Our final exam is on Thursday. This is actually the first time it's scheduled that way. Usually it's on the next class meeting after our last class. So you got a little more time to worry about it, study, and definitely feel free. I'll be available to answer questions. I'll see all of you on Friday night and after the opinion, but I'm always available by email to get started studying early. That's always a good thing. So send me questions that you have. We'll look forward to getting you through that portion of it. You won't have those other classes. All right, we'll stop there for today. We'll see y'all on Thursday.
Doug Aaron, I didn't get anything.